Thank you, Chairperson. I'm Tazaki from Kyoto University. Today I'll present the vascular spasm during the EVT procedure for the BK region. The patient is a 42 years old male, was admitted to our hospital due to the R5 to ulcer for 1 month. And the IV prostaglandin did not improve the symptom, and rest pain need morphine for his sleep. And his risk factor is only the smoker, and he already started the prednisone due to the eosinophilic leukocytosis, including the esophagitis and nerve paralysis. And he also using the warfarin due to the PE, DVT history. And his lab data, the rheumatoid factor and the anti-nucleotide antibody is negative. And ABI is normal, but the SPP was decreased at the left foot. So we decided to need the perform the EPT for his left leg. And this is the initial angio. As you see, the no stenosis at the proximal portion of the tibial artery, but the distal part of the ATA and the PTA is also occluded. And the plantar artery is supplied from the collateral artery from the distal ATA. So after the via crossing, we perform the thrombus aspiration, and we get the organized thrombus. After the thrombus aspiration, the blood flow to from the PTA to the plantar is still not so good. So after that, we dilated with a 2-millimeter balloon catheter. And after that, this point is not dilated with balloon catheter, but the severe spasm at the proximal portion of the PTA. It's a control angio. So after that, injected the nitro, but did not improve the spasm. So after the additional nitroglycerin, verapamil and alloprostatil prostaglandin, and long inflation with a 2-millimeter balloon. I'm sorry. After that, the blood flow was improved to the I'm sorry. Left foot. But once the rest pain has improved, but they worsening again 3 days after the first EPT, and the SPP is still low in the left foot. So we perform the EPT again to his left foot. And the initial angio of the second EPT, the PTA, occluded again. Oh, I'm sorry. Oh. So we pass through the guide wire again and aspiration, and dilated with 2-millimeter balloon. And also, PTA is easily occluded again, maybe. So we perform the plantar arch angioplasty with 2-millimeter balloon. Now, easily, wire can cross the dorsal artery from the retrograde axis. After the dilatation of the dorsal artery, oh,
Just give it a second at me.
Oh, I'm sorry.
No, it's okay.
We experienced a severe spasm at the proximal portion of the ATA. This is not dilated. So after that, we again injected the nitroglycerin, verapamil, and arosprozil, and the long inflation with 2.0 millimeter balloon. So the blood flow from the ATA and to the ATA to the PTA was recovered. But as you can see, there's still stenosis at the distal portion of the PTA to the plantar artery. So the IVAS shows still organized thrombus at the distal portion of the PTA. So we dilated with scoring balloon, 3.0 millimeter, and after that, long inflation with 3.0 millimeter long balloon. In the final angio, we can get a good flow from the PTA to the plantar artery. But the dorsal artery is still occluded. But the patient's symptoms is clearly improved after this procedure. So after that, the rest pain was improved, and SPP elevated at the dorsal portion. And additional to the warfarin, we started the xylostazole, diltiazem, and isozolbil patch at his dorsal. So after this procedure, he transferred to the department of the clinical immunology and diagnosis as EZPA, eosinophilic granulomatosis with polyangiitis. So additional to the prednisone, immunosuppression therapy with cyclophosphamide, and after the EVT, the ischemia did not recur, and wound was healed after the procedure. So we sometimes experience the wound due to the vasculitis or autoimmune disease. The effectiveness of the EVT was reported for the CLI due to the autoimmune disease. But so such a case, we should consider multidisciplinary approach for the CLI due to the autoimmune disease. So to this case, we experienced a severe spasm during the EVT for the CVI due to the EGPA. Refractory spasm was improved after the nitro, calcium channel blocker, and prostaglandin. The ischemic ulcer does not recur after the immunosuppression therapy. Thank you for your attention.
Thank you for a good case. Let me ask you something. Since you were having so much spasm, I feel like the more ballooning you were doing, the more equipment you were putting down, it was causing more spasm.
Yeah.
Any consideration of putting this patient on anticoagulation and just like a nitro drip through the sheath or cardine drip or something to help dilate the arteries with time rather than keep doing balloons?
Yes. After the nitro injection, little bit recovered the spasm, but still very severe spasm. So
right.
Additional to the calcium channel blocker and prostaglandin, and then the occluded region dilated with balloon again.
Sometimes you can put like nitro drip or cardine drip for 12 hours.
12 hours.
Yeah, you know, like long infusion with heparin to anticoagulate, get them to the unit, bring them back next day. You do an angiogram, and then it's much better because you give it over an extended period of time.
It's a very good option.
Any other thoughts?
Did the patient have Raynaud's phenomenon or no Raynaud's in the hands?
No
Raynaud's.
Only the hood.
In retrospect, if you had a diagnosis made of eosinophilic granulomatosis, in retrospect, do you think that all of that angioplasty would not have been needed because it was all vasculitis, or do you think that there is a component of atherosclerosis? I mean, I was showed that there was plaque, but I mean, would like to hear.
I think that this patient has organized thrombus at the distal portion of the PTA. So after the IV prostaglandin use, patient have the severe pain at the left toe. So I think this case needs angioplasty if they are considered from the retrospective.
Perfect. Thank you very much.
Thank you.